Good evening, everybody. Welcome to this session of the Pulmonary Circulation Journal Club. Today we have Christophe Guignabert from the University of Saclay, Paris, France, and I will introduce the topic a little bit. I think we are all thrilled by the entrance of sotatercept as a potential drug for pulmonary arterial hypertension, the first in class targeting proliferation. And I think we've all been looking for this drug for a long time because it's one of the first drugs to target overactive TGF-beta and SMAD2/3 signaling. It particularly inhibits the activins. I think the interesting study that we will discuss tonight will be about not about the role of activins as a target for treatment, but the question is whether they say more and if they can be used for diagnosis, and if they do tell you something about the prognosis of the disease. And I think we have a very nice publication from this summer from Christophe Guignabert and his group, indicating whether and how activins are relating to a severity of disease. My name is Jurjan Amond from Amsterdam, and I'm here together with a number of other members from the journal club of the Pulmonary Circulation, and we will moderate this session. But we will first start with the presentation, and Christophe, the floor is yours.
Thank you very much, Jurjan. Thank you for hosting this seminar and extending the invitation for me to speak. So I'm currently Christophe Guignabert. I'm currently affiliated with the French Institute of Health and Medical Research, INSERM, at the University of Paris-Saclay in Le Kremlin-Bicêtre. And actually, I'm very excited to share with you some of our recent findings around the activin pathway. And we will also discuss, as you underlined, Jurjan, to discuss how dysregulation in the activin pathway actually can contribute to the pulmonary vascular remodeling that is associated with pulmonary arterial hypertension, or PAH. So actually, PAH, as you can see here, is classified as group 1 in the current clinical classification of PAH. And it is defined by a mean pulmonary artery pressure over 20 millimeters of mercury at rest in presence of pulmonary vascular resistance of at least 2 Wood units with a normal left heart filling pressure. In this specific form of the disease, in PAH, the increase in pulmonary pressure is actually due to an intense pulmonary vascular remodeling, a remodeling of the small precapillary pulmonary arteries with a diameter lower than 500 micrometers, as you can clearly see here on this concrete example. So this pulmonary vascular remodeling can take various forms, with a key feature being medial thickening that may potentially lead to the complete obliteration of the vascular lumen, as we can see here. This remodeling is also frequently associated with varying degrees of inflammatory cell infiltration, which has the potential to organize into tertiary lymphoid tissue, as seen here on this image. In addition, there is also the formation of specific complex vascular lesions known as plexiform enzymes. And even if during these last few years we better understand the pathogenesis of PAH, the specific mechanisms that driving this structural and functional remodeling of the pulmonary circulation remains unclear. And among all the molecular actors and signaling pathways that contribute to this pulmonary vascular remodeling in PAH, one stands out as playing a clearly determinant role, and this pathway is a BMP-TGF-beta pathway. Despite the complexity of this pathway, with over, as you can see, more than 37 different ligands, 7 type 1 receptors, 5 type 2 receptors, not to mention all the pathways, inhibitors and activators, we can simplify this pathway by focusing on phospho-SMAD158 on one hand and phospho-SMAD2/3 on the other hand. because actually the phosphorylation of these MAD proteins are particularly important for the maintenance of the pulmonary vascular integrity. However, in PH, there is a progressive and unexplained increase in phospho-SMAD3, as illustrated here in red in our immunofluorescence staining of lungs. We found a clear elevation of phospho-SMAD3 in the nuclei of both the dysfunctional pulmonary endothelial cells, but also in the dysfunctional PA smooth muscle cells in PH compared to controls without PH, as you can see here. And therefore, based on these findings, we questioned if PAH is actually associated with defects in the activin pathway, as it is known that an excessive activin activity could at least partly explain the increase in phospho-SMAD3, but also contribute to the pulmonary vascular remodeling. Very briefly, here is the activin pathway. So it's known that the activins bind with a strong affinity to ActR2A and ActR2B. And this complex actor is able to recruit a type 1 receptor, either ALK4, ALK2, or ALK7. And this complex, this tetrameric complex with activin, actually is able to phosphorylate SMAD3. And when SMAD3 is phosphorylated, it translocates into the nucleus with SMAD4. And this complex is known to modulate a panel of genes that not only disrupt endothelial cells, preventing them from forming tubes, for example, or it's also able to disturb PA-SNCs, promoting their accumulation in the media. And it's also known that this pathway, when it's activated, it can enhance the recruitment of inflammatory cells. So we have conducted a series of experiments to assess the level of activin in human and experimental pH, as you can see here. And we found that activin A is overabundant in the serum of our patients. There is about a 2 to 3-fold increase in activin A levels in the serum of PH patients compared to controls. And these were reproduced in our in vivo animal models in the three most widely used experimental PH models, including the chronic hypoxia-induced PH, the monoprotein-induced PH model, and the Sugen hypoxia. Based on these results, we then have chosen to investigate the levels of activin A, activin B, and its different inhibitors, endogenous inhibitors, like inhibin A and B, follistatin, and follistatin-like 3, known as FSTF. We have followed the levels of these proteins in the blood of 2 large cohorts of newly diagnosed patients with PH. Initially, 80 patients from the French effort cohort were examined as a discovery group, and the findings were confirmed through validation in a cohort of patients from the UK. And our findings, as you can see here, reveal that at the time of diagnosis, so in the second line, there is an increased level of activin A, activin B, follistatin, and follistatin-like 3. However, following the introduction of specific pH treatments in the last column, we can see that these levels tended to decrease. Interestingly, we also observe a significant reduction in inhibin alpha levels, which is a known activin inhibitor when compared to healthy subjects. Then we examined if there was an association between these protein levels and the survival of a patient on it. And the data reveal, as you can see here on this Kaplan-Meier survival curve, that there is a correlation between elevated levels of activin A and follistatin 3 with adverse outcomes, which make these two biomarkers, activin A and FSTL3, as very interesting prognosis biomarkers for the disease. To understand what was happening at the pulmonary level, we stain the two beta chains of activins in red. And as you can see here, the chains that compose activin A, beta A, and beta B, they were overabundant in the lungs of patients compared to controls. And we found also that the main receptors for activin, ATR2B and ALK4, were also overexpressed in lungs of patients with idiopathic PAH as compared to controls. These human findings are of importance because we have shown in collaboration with Professor Emoto and his team in Japan that the overexpression of activin in mice actually worsened pulmonary vascular remodeling induced by chronic hypoxia. Why? Its deletion is protective in experimental model in mice. In conclusion, taken all together, this data shows that the activin pathway is overactive in PH and that circulating levels of activin A and FSTL3 are actually two promising prognostic biomarkers. But more research is clearly needed in this field, and we have currently two ongoing studies trying to understand the origins of the dysregulation of the BMP-TGA beta pathway in PH, and also another study that want to answer if this deregulation of the activin pathway is a common factor across all forms of PH. And before to conclude my presentation, I would like to thank all the members of the team, especially Mark, Lee, Laurent, Olivier, and Athénaïs for their help in this research. And I'm ready to answer your questions. Thank you for your attention.
Thank you very much, Christophe, for this very nice overview, very to the point, and very clear. I think people can just ask questions by either raising their hands or by putting questions in the chat. I will kick off with like a general question. The prognostic value was mainly determined by the circulating activins. You also showed some stainings of the activins in the lung and the lung vessels, but I'm wondering what's your idea about the source of the activins? Do you have any idea about the type of cells? Does the heart also play a role in there, or because that's the most important determinant in terms of prognosis? So do you have any ideas on that?
Yeah, thank you for these important questions. Actually, we know that activin A is produced by several inflammatory cells, including monocytes, macrophages, but also the endothelial cells itself is able actually to produce activin A under different stress, including the exposure to chronic hypoxia, for example, to oxidative stress, or to certain cytokines. So I think we need more study in order to clearly identify why there is this overexpression of activin A in lungs of our patients, clearly. But the inflammatory cells is a very well-known source, actually. So I don't know if I answered all your questions, but
Yes, definitely. And then yeah, now I think you nicely pointed out in the cartoon in the beginning that they predominantly signal to the endothelial cells and the vascular smooth muscle cells, and disturbing TGF-beta signaling there.
And as you say also, Johan, this pathway is also very important for the heart. So we need also other studies in order to precise which cell types is perhaps able to produce activin in the cardiac tissue.
Yes, yeah, I'm very indeed very curious for the action in the heart. I do see one raised hand, and there is one question in the chat. So Marie-José Gaumans, please go ahead.
Yeah, so very, very nice to have the overview. And it's always interesting to see all these, it's such a easy pathway with so many different impacts on physiology. So you've looked into activin A and B, but of course we also have AB.
Yeah.
Were you able to look at the dimer as well? Because I think the crux in all is that the binding affinity of the activins is different depending on the combination of the type 1 and the type 2 receptors. And maybe that's where also a difference might lay in the impact it has on the lungs or the circulation of the heart. Do you know anything about the AB form?
No, definitely not. It's very difficult to have a very good ELISA kit to assess AB because actually you detect the beta chain. You
Yeah,
have different one, beta
yeah,
A, beta B. So we usually you follow the chain beta A. It could be activin A or AB.
yeah,
And when you stain for beta B, it could be activin B or AB. So it's always difficult to know which is really present in
yeah.
the
And
blood or in the lungs.
and
So,
did you check on the receptor availability? So does that change over time?
no.
That we know from other diseases that the activin type 2As might switch to a type 2B, and then you get another receptor type 1 in the complex. Do you have any insight in what happens with the type 2 receptors or the type 1
It's a very
receptors
good
for activin?
question. It's a very good question, Marie-José. Thank you. We plan to assess the activin pathway in our animal models because in the animal models we can have access to the early stages of the disease,
Yeah,
which is
perfect.
very difficult to have access in our patients actually because when they are diagnosed, it's already a late
Yeah,
stages.
yeah,
So these kind of experiments are ongoing in the lab, and I think they are very important, as you say. Perhaps at
yeah.
the beginning we have an increase in activin A that is after
Maybe we should go back to the old-fashioned cross-linking to see which receptors actually are present.
I totally agree. Thank you.
Yeah, yeah. Well, thank you. Very nice.
So I think we can continue with the question from the chat. Mariam, after that, I'm coming back to you because I see you also have the raised hand. Ziudai in the chat asks, as SMAT4 works with phosphosMAT2/3 to activate the downstream signaling, what is the expression of endothelial SMAT4 and phosphosMAT159 in the endothelial cells from PH patients? You have any ideas about that, Christophe?
Yeah, thank you very much, Ziudai, for your questions. I totally agree. SMAT4 is shared actually for the phosphorylation of SMAT2/3 and SMAT158. They need SMAT4 to translocate into the nucleus. SMAT4 is very ubiquitously expressed as SMAT158 and 2/3. We know that inflammatory cells and endothelial cells express a lot phospho-SMAT2/3 and 158. But it's a good question, but I don't think there are really difference in expressions. So Marie-José, you answered to the question. We have never seen a difference in SMAT4 and pH. Yeah, you're right. There is no differences in terms of expression levels between pH cells and control cells. They are expressed in both of them, I think. I don't know if Marie-José, you want to complete my response.
No, I agree. I don't think they are the limiting factor in the signaling cascade.
I think so too.
Thank you very much. Mariam, please
Okay,
go
then
ahead.
thank you so much for the nice presentation and wrapping up such interesting data. I was gonna take you to the right ventricle versus the lung side of the pH, and I was wondering if you have looked into these factors or your activins A and B or SMADs in the right ventricles of your experimental or the human models that you have, and whether they change, and whether you think tissue levels versus serum levels would make any difference in that. And my last question, to make it a little bit more complicated, is that whether you have looked into the difference between the right ventricle and the left ventricle, because, you know, these signalings are also seen to be involved in the, you know, heart failure, left ventricular heart failure. That's it. Thank you.
Thank you very much, Mary, for these questions. They are very important questions, actually. We didn't have the chance to look at activin expression or the different members of the pathway in RV versus LV, but I think it would be very interesting to do this kind of experiment. And we don't have really access to, I would say, tissues from patients. We have some of them, but not enough to perform this kind of study in humans. But it will be very interesting. And regarding the difference between circulating levels and tissue levels, this is also a very important question. Actually, we don't know if what we are assessing in the blood is really the reflect to what's happening in the lungs. But I think we it can help to I think it's a reflect what's going on, because we have correlation with the severity of the disease. But definitely it's a good question.
So
we
for
say the
the
lungs.
tissue, for the human tissues, we have some, so we're more than happy to work with you guys. And another thing is that Dr. Sebastian Bonnet is from Canada, right?
Mhm.
They have a lot of tissues, and they have it human tissues from compensated and decompensated state of pH for the RVs. If you're interested in RVs, since we're focused, we love RVs, so all of our
It's
concerns
very
come about RV.
The
So
activin pathway is particularly important for the survival of cardiomyocytes
exactly,
when
if
they
it
are
is,
friends. So
mhm,
it's relevant, actually.
that would make sense. Exactly. So we're more than happy to help, and the groups are there. And thank you so much for the
Thank
response.
you very much.
Thank you again.
I would be very happy to
Thank
contribute.
Yeah. Another question in the chat. What is the upstream of increased activin expression from the endothelial cells? Is activin expression different based on the pH subtype? And are there inflammatory cells in the lung that express inhibin or activin?
Yeah, it's also a good questions. We have ongoing studies trying to understand why we have this increase in activin in pH. We know from the literature that the oxidative stress, the hypoxia, and different cytokines can induce the expression of activin A when you stress endothelial cells. So we need more study to understand the reason, actually. And to have access also to the kinetic will be very important. There is a question from Jim.
Yes, Jim White. Please go ahead. The floor is yours.
Bonjour, Christophe.
Bonjour.
Thank you so much for this really elegant presentation. I have two very disparate questions. And I'm pretty sure one doesn't have data and is related to what Miriam asked. For those who are much more interested in endothelial cells and smooth muscle cells and don't know so much about some of the clinical data, interesting observation from the sotatercept data is that stroke volume, especially for normals, didn't improve as much as people would have expected for the very large decrements in pulmonary pressure that were observed. And so I'm sort of tangential to Miriam's question, but definitely related. Do you know about the role of either activins or BMP in the sort of normal development and function of the RV that might allow you to postulate how activin overexpression, whether in the serum or tissue, might have influenced the clinical physiologic outcome? That's the first question. I'll let you take it, but I still want to ask your other one because I think you'll be more interested.
No, thank you very much for this question. So clearly, it's a very important clinical question, we know, but we don't have really an answer from the basic science, I would say. So clearly, okay. I'm sure they play a role in cardiac development. I'm not the good.
You're not the person.
Okay. Question, but
okay. So then the second question is definitely for you, which is, does the data set the beautiful data set that you just accumulated help shed light on this BMP controversy that you've been a part of? Does it help you integrate some of the data that you've had that's been in contrast to other people's data about whether the BMP peptides themselves might be useful, or whether the specific BMP receptor is or is not involved? Does this activin stuff shed light on that?
Yeah, so there are studies from the literature from Tues, the team of Tues. They gave sotatercept to rodents, and what they observed is that they were able actually to attenuate the phosphorylation of SMAD2/3, but they did not really observe changes in SMAD158. So it seems that sotatercept is clearly an inhibitor of the phosphorylation of SMAD2/3. Sotatercept is a soluble activin receptor type 2A, and therefore is able to bind many different ligands, activin A, B, GDF8, GDF11, but also other ligands like BMP9 and BMP10. So, which is particularly interesting because we know that this pathway is particularly important for the maintenance of the integrity of the pulmonary vessels. So we have an ongoing studies trying to clearly understand the mode of actions of sotatercept. But it seems that he is able to affect BMP9 and BMP10, and perhaps sotatercept is not only an inhibitor of activin, he has other actions. So,
but specific, I apologize, specific to your research in BMP 9 and 10, does the activin side of the story that you've been just now telling us about help to elucidate why your lab and, say, Nick Morell's lab came to different conclusions about those peptides?
So we need more. Regarding the BMP9, you are asking about the BMP9 effects. So when Nick Morell administered BMP9 to rodents with PH, he observed a beneficial effect. And what we have observed in the lab here is that if you take deficient rats or mice within BMP9, they are protected, which can be controversial, but actually there are many explanations about that. And I know that there are ongoing studies that trying to reproduce what Nick Morell has done, and I'm not sure about the results, but it would be interesting to wait before to conclude about the role of BMP9. I think several studies and several labs found that BMP9 actually it's not playing a very good role. It can promote endo-NT, it can is a vasoconstrictor. So I think we need more study. And I know that Tues is actually working on this aspect.
See.
Okay,
Thank you so much. Yes, please continue putting your questions in the chat. In the meanwhile, I'm going to challenge you a little bit and see whether you want to do some clinical some clinical statements as a preclinical researcher. So I'm wondering whether this paper will take the field in terms of diagnosis, risk stratification, and also whether it can be of help in treatment. So I will start with the risk stratification because I think your group also has published a lot on the risk stratification. I was wondering, the first thing I noticed is that in your paper you had the Cox model to predict an adverse outcome, and you found that it has actually the predictive value of the activin. It remains after correction for anti-proBNP. So which is represented in table 4. I was wondering the anti-proBNP or the proBNP itself doesn't seem to be very predictive in this model.
Yeah, it is predictive, but activin A and FSTL3 are better predictors than anti-proBNP.
Okay,
in our cohorts.
So does it have like added, yeah, like adding them up in like, but probably that is still ongoing work or something you want to work on in the future, like adding this up or adding it to existing risk models? What's your vision on that?
Yeah, I think in the field we need biomarkers in order to stratify our patients, and also we need theranostic biomarkers. So we have to clearly found very good biomarkers. There are many in the literature that has been identified: GDF-15, uric acid, creatinine, as you know, but none of these biomarkers are actually therapeutic targets in clinical practice. This is why I think activin A and FSTL3 are particularly important among these biomarkers, because they are perhaps also very useful to predict the response of the sotatercept. But we need a large cohort. We have to wait. We have really to increase the number in order to use them in this way. So we have ongoing studies in order to precise if these biomarkers are also theranostic biomarkers. It could be. I don't know.
Thank you. I'm curious for those data, but probably have some patience. And the other thing is, it's the role of these the like the biomarker function of activins in predicting a treatment response. So I was wondering, because the treatment response to sotatercept, it looks, at least from the first studies, it can be quite heterogeneous, with some people responding very strongly and others like a more mild response. So could those activins, so measuring activins, could it help in determining which patients are candidate for sotatercept or early sotatercept or whatever? So what's your vision on that?
Yeah, I think clearly we have to perform this kind of experiments, but as you know, there are not enough patients treated with sotatercept, and we have small cohorts until now. We are trying to do this experiment in the lab, but yeah, I think we have to wait, but these are future studies that we will need to do.
Perfect. I was looking in the chat, and I don't see any raised hands. So this is, I think, if you have any questions left, Miriam.
Sorry to ask you another question. Just crossed my mind. So I think, if I remember correctly, based on your first or second slide, it was that on the data section that you saw basically the same level of changes in activin in all three of your rat models, right?
Yeah.
And in humans was also pretty much significant. I was wondering if you've, and mostly the reason why I asked this is that you may be able to, because we are somehow limited to what we can do with human samples or in humans, and I was wondering if you want to take it to the other animal models, or such as in mice, where you would have more, options to genetically modify or manipulate anything that you want, and whether you've tested it in mice even.
Yeah, so in collaboration with Professor Emoto in Japan, we have overexpressed activin A in mice. And these mice actually are more prone to remodel pulmonary vessels than wild-type mice.
Interesting.
And when we delete activin, they are protected against chronic hypoxia-induced PH. So clearly, when you manipulate activin, you affect the pulmonary vascular remodeling. So this is, I think, a very nice demonstration. We need more study. We need to follow the kinetics. We need to precise the role of activin A in the RV, etc. So, but it's possible to
in vitro
manipulate
also,
activin.
yes.
Yeah. And in vitro, it would be very important, because we can have access to human cells.
Exactly.
I think it's more important, yeah.
Exactly. Thank you.
Mariam.
Well, that having said, I want to conclude on this journal club. And first of all, by thanking Christophe Guignabert for his a wonderful talk. Thank you for giving the talk here and explaining the work that you have done. And I'm quite sure that we'll hear more about it. So very curious for the follow-up studies. I also would like to thank the audience, a pretty impressive audience. And I can promise that the next journal club will be from the Pulmonary Circulation Assembly will be in spring. So please come back. And having said that, I would like to thank you all for those who are currently traveling or who will travel tomorrow to the PVRI. Good travels, and hope to see you all next time in the journal club. Thanks a lot.
Thank you very much, Ariane. Thank you to everyone. And see you soon.
Thank you. Have a good one.